was one question, which is your work affected at all by the funding cuts by the United States for example, PEPFAR?
Okay. Thank you so kindly. Yes, to a smaller extent than the other colleagues that were more, for instance, in the infection space. We're doing infection, but to a limited scale. So therefore, our collaborators that were supposed to work with us and therefore pay for the isotopes will no longer be doing so. So us directly at the moment, not so much, because we had been working with more Europe than America. Anyway, for some reason, we work with EU more. So, for instance, EU, we've got a grant, 22 million per annum, that they help the people of South Africa so that we can have better isotopes and access to them. Yes.
That is good news. Thank you.
Yes.
Kwasi Gabuza asks, how applicable to other affordable scans like ultrasound?
Okay. Yes, ultrasound. So as one speaks about nuclear medicine, without really having clear patient pathway, it will really be speaking in vain. So you've got to start with all the non-invasive, more readily available modalities like ultrasound that will identify patient one to patient two who should be sent to nuclear medicine, who should be sent to cardiology. For instance, just 2 days ago, sitting analyzing a PhD grant of somebody that is going to use ultrasound, but in a remote area, not in a sophisticated area, that would help a GP, a nurse, a clinical associate to say this and this features means that, and therefore the patient will not be wasting time. So it is applicable, and I'm happy that, of course, it doesn't have to be nuclear medicine. It must be in all modalities. There are really means and ways of trying to come with a reliable interpretation and diagnostic ways. Ultrasound, X-ray, and again, things like chest X-ray. Sorry, I'm talking a lot. Like chest X-ray, for instance, we've just done. I have a PhD student of mine that has just finished on trying to see when you have a chest X-ray and you are sitting remotely, what must you say to say this is TB and this is not pneumonia? And that's really simple things that I help, because if you miss it at that stage, the patient gets to be lost. Yes, it is applicable, really.
Thank you very much. Zama Moni asks, what would the prediction criteria be for progressing to clinical trials? And how do you ensure that AI is being accurate?
Yeah, I think thanks for that. But predictors are going to be basically clinical trials are different from different times. And usually low middle income countries tend not to do clinical trials. And clinical trials are important to bring those expensive drugs for free to our patients. So the more we do this and say that, let's say, for instance, in Belgium, they would have said the prediction is that if somebody has got a hemoglobin of 20, platelets of 30, then he must progress and so on. But you find that in South Africa, it's actually not the same situation. So those predictors of saying who must go to the clinical trial from routine might differ slightly. Hence, that's why we advocate that, yes, we must do that. At the initial stage, we'll take predictors that are really set out by other people. Those predictors will have been, say, the histology must say this, the blood must say this, and then, of course, the scan must say that you have more than 3 lesions first. But those things shouldn't be cast in stone, and we shouldn't stick to them. After having done fewer patients and fewer trials, we should set our own trials to give better predictors. We can say, for instance, in an African setup or with somebody that is of a certain socioeconomic status, you also have to include, for instance, the renal scan of, say, 30 and not 40, because if you include 40 for him, that patient will not cope well. So predictors are a moving goalpost depending on what we get on our side. And then, of course, we've got to sequence the therapies. The trial might say to you, start with drug A and not drug B. But if somebody's got a poor prognosis from the beginning, then you might have to start with drug B and not A, as say for instance in Germany. So it's not as easy as that the AI will help us based on European models. It will help us from the beginning, but we have to do our own ones. But we need big data. Hence, I've shown that map of Africa that, I mean, in South Africa, in the country, we've got to have our own human and normal data so that we can have better predictors. As I was showing the brain scan for dementia, it might be that as well that for you've got to normalize to a normal brain, but the current we normalize to a brain that is derived from Europe, but that might be wrong, for instance. We might over or underdiagnose.
Right. Yes. No, we definitely need our own data, and you're participating in collecting that data, of course. So I think we're slowly making progress. Busi Aland says, "Thank you, Prof. Sathekge, for your powerful presentation on nuclear medicine as a game changer. Given the precision of nuclear theranostics in targeting specific molecular pathways, is there scope to apply similar diagnostic frameworks to multi-component integrative formulations, particularly those derived from indigenous plants? Could nuclear imaging or tracer technologies be used to track compound synergy or bioactivity in vivo?"
Yes. So, of course, indigenous medicine has not been given a fair chance, but probably because maybe there hasn't been objective way of analyzing it. Let's say, of course, there's indigenous medicine that's supposedly to do X and Y. I think one of the fairer trials, except just looking at the patient's outcome and clinical follow-up, it could be by in vivo imaging. I mean, we can have the pre and post medications that are given, so conventional medicine versus indigenous medicine, and compare objectively, not only on the clinical. That's how one way we could help, but we could then also ask in an in vivo in a laboratory to say what is contained in that indigenous medicine, and then we can see if there's anything that we can label, and then actually then do an imaging, not a generic imaging, but an imaging targeting what that indigenous medicine has. Say that indigenous medicine happened to have, I'm just giving an example, somatostatin or so, and then you then, okay, but this is actually containing this. So if we image going with this type of a receptor, that's how we can actually track it better, and or utilizing nuclear medicine later on. If we can see it, we can treat it to target with a radioisotope that can treat. So then your payload for treating can become a nuclear medicine isotope if that is feasible. So indigenous medicine has to be studied, but then of course, together with the other chemists. So there's computational way of actually trying to analyze what biomarker we can extract to target and help whatever the medical application that is given to us.
Okay, thank you. Last question. Thavrin Manicum says, "Thank you, Prof. Are you doing any or a planned future research in advancements or improvements in brachytherapy for prostate cancer? For example, in brachytherapy, there's a risk of radiation exposure to other tissue organs beside the prostate."
Yes, brachy, of course, inserting those isotope and then it irradiates. So brachy is starting to be used less and less, for instance, in prostate cancer, because of course, obviously the best, I suppose, with the robotics, which is, sorry, I didn't get to that, but robotics is another for the industrial way of doing medicine. And then robotics would actually be now targeting how to operate those, which is the first prize, if you can. But if it's not operable, then nuclear medicine isotopes will, if we image and when we can target it, we can then treat and then shrink it, and then we can still operate, or we can just use nuclear isotopes to try and target, but not in a form of brachyseeds, of course, just a simple IV injection, but then it won't go to other areas. If you have imaged and seen that it's going there, you can actually try and do that, but you can then assist phototherapy and to external radiation to actually target a certain area. If we have image, then we can really then be directed toward that specific small area, not looking at it morphologically, but looking at where it's active. So in a combination where we can advance, we are advancing and we are helping to make sure that there isn't benefit of irradiating the normal tissues. So yeah, there's various things we can actually do to have, and then there's ways that that's gonna come that we can do intracavitary insertion of our nuclear medicine isotopes, like alpha therapies that travels a short distance. So they are stopped merely by a paper. So if you put them exactly in that specific area, especially say in the brain area more than the prostate, but the same will happen in the prostate, can also happen to be futuristic in that way. So to really say not taking your time. And see, I think nuclear medicine is going to be seriously a serious pillar of oncology going forward. As we speak of oncology, radiation, and surgery, it's going to be one of those pillars that you cannot speak about oncology without speaking about nuclear medicine to avoid
Totally.
things like brachy.